This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new, welcome. And for our regulars, welcome back. Just as a recap, I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been coming to you since 2016. This is our 10-year anniversary of the podcast. I've been saying it all year. I'm going to keep saying it all year because, again, I cannot believe we made it this far. So I'm very, very happy about that. And thank you all who are listening. And this particular series, as I've said in the past, I'm not crazy that we have to make. That means, in my opinion, we're going backwards. But it's an important thing that we do to get the information out to all the healthcare providers in the hospital setting or even the outpatient setting about these vaccine-preventable illnesses. Go back in time, kind of talk about why we initially invented a vaccine, what they were like before. So when you have vaccine-hesitant families who are asking questions, all that information is fresh in your mind. So you can hopefully guide them towards the right answer of keeping us vaccinated. But it's important to do. Now, clearly, I can't do this alone. We have been very fortunate to partner with the UPMC Children's Hospital Pittsburgh Division of Pediatric Infectious Diseases, who have given up their time and expertise. We've had 2 experts on per episode at least, and that's no different today, helping us walk through this. So they are our partners with this, and we couldn't do it without them. And in random order, we're going to introduce today's experts to talk about rotavirus and varicella. So first, we are welcoming back to the show Dr. John Albert. Dr. Albert's an assistant professor of pediatrics in the Division of Infectious Diseases here at Children's Hospital of Pittsburgh. He completed his pediatric residency at St. Christopher's Hospital for Children and his ID fellowship at Children's National Hospital. And during his fellowship training, Dr. Albert served as a medical officer at the FDA's Office of Vaccine Research and Review. His clinical and research efforts focus on the care of immunocompromised children, including transplant recipients. He currently serves as the Associate Director of the Pediatric Infectious Disease Fellowship Program here at UPMC Children's Hospital of Pittsburgh. And we're going to welcome them both together. So our second guest, expert guest today, for the first time on the show, we're welcoming Dr. Brian Campfield. Dr. Campfield's an assistant professor of pediatrics and an attending physician at the Division of Pediatric Infectious Diseases here at UPMC Children's Hospital of Pittsburgh. He joined the faculty in 2013. He's a physician scientist whose work centers on host pathogen interactions with a research program that explores novel mechanisms of pulmonary immunity, immune development, and pediatric Lyme disease. His scholarship includes high-impact publications in journals such as the American Journal of Respiratory and Critical Care Medicine, Clinical Infectious Diseases, Cell Reports, and he has more than a decade of continuous NIH funding, including K&R awards. He graduated from the University of Virginia and went to the University of Pittsburgh School of Medicine, did residency and Infectious Disease Fellowship right here at Children's Hospital of Pittsburgh, board-certified pediatric infectious disease doctor, and has been on Pittsburgh's top 10 doctors for 5 consecutive years. Doctors Campfield and Albert, welcome to PHM Pittsburgh. Thank you for being on.
It's an honor to be here. Congrats on the continued success of the podcast.
Yeah, thanks. Thanks for having me join the party. I can't believe it's the first time. 10 years in. You took 10 years to get me on.
Years, that's right. Saving some of our best people for later on, right, Brian?
So sounds good.
Let's do our disclosure since it's a CME podcast. I will go first, and John, I'll kick it out to you, and then Brian, you're batting cleanup. So I have nothing to disclose.
I have no disclosures either.
I have to disclose that I do consulting work very occasionally for Pfizer to look at the epidemiology of Lyme disease in children. It has no influence or bearing on any of the work or any of the discussion that we're going to have today.
That is fantastic. Thank you for that. Now, we're going to start with varicella today, and we're going to then move to rotavirus. And I believe with varicella, we're starting with you, John, right? So take us back, John, Microbiology 101, first year med school. Tell us about varicella.
Yeah, so varicella zoster, it's a double-stranded DNA virus. And importantly, it's an alpha herpes virus. And so herpes virus just means that it's a virus that when you're infected with it, it establishes long-term latency in the body. Under normal conditions, the immune system keeps that under check, keeps it suppressed. But as we'll talk about, that's not always the case. And it's really closely related to HSV1 and HSV2, follow similar principles, and so we'll kind of see some reflections there between those viruses.
Well, that's fantastic. Thank you for that, John. Now, epidemiologic data, how much did we used to see before the vaccine and how much are we seeing now?
Yeah, so before the varicella vaccines were licensed, there were about 4 million cases annually, which isn't a precise measurement. That's just the annual birth cohort at the time. Everybody had varicella. I come to confess on air live that I attended a chickenpox party to be inoculated myself. I regret it ever since, but that's the truth. That's the facts. And so for the most part, I think, as you well know, the majority of children with chickenpox don't have severe complications, but as we'll talk about, some do. And among these varicella cases, each year there are between 11,000 and 13,000 hospitalizations and about 100 to 150 deaths annually, and a lot of other morbidity associated there, and that we'll kind of talk about. And so, the Advisory Committee on Immunization Practices, I think this has been discussed on the podcast before, but they're the advisory group within the CDC that gives recommendations for how vaccines should be implemented on a population scale. And so they first started with just recommending a single dose of varicella vaccine between 12 and 18 months, and then there were other protocols for catch-up vaccination before 13 years of age. And then in 1999, it was needed for school entry. And so with that first vaccine, after about 5 years, the incidence of varicella fell by about 90%. It was really successful. But then there started to become more kind of sporadic breakout cases of varicella, particularly in school-age children. The varicella vaccine gives really durable immunity, but it's not 100% for everyone. They may not all respond the first time. So in 2007, that's when the ACIP, recommended a second dose of varicella vaccine for children 4 and 6 years that later became incorporated in MMR and the MMR-V vaccine that we all know and love. And then this second vaccine really reduced the incidence of varicella by 97%. And in particular, it's, the younger children who don't have the opportunity to get vaccinated who really benefited from this the most.
97%. That's remarkable. Okay, wonderful. So then, because of the times we're in and vaccine hesitancy is growing due to various reasons, we may start to see this disease come back. So what type, if for those of us who are in a hospital or even outpatient setting, if a patient comes in with varicella, what are we looking for? How are they going to present?
Yeah, so the most common thing you'll see, chickenpox. I had it, my pappy had it, my grandpappy had it. And so I guess kind of just breaking things down, maybe let's start with the prodrome. So usually about 24 to 48 hours before you erupt in vesicles, children typically have fever, headache, anorexia, abdominal pain, just a kind of a non-specific flu-like illness. And you may not think anything of it in the absence of like a proper exposure, particularly because varicella cases have become so common in the U.S. Knock on wood here. But then, after that initial period, there's about a 10 to 21 day incubation period. But after that exposure, you start to develop skin lesions. And these are lesions that really change over time. So they start as kind of these non-specific red macules. And so they don't start out as really classic vesicles. And so that, can sometimes be easy to fool clinicians. And typically the first lesions start around the scalp, the face, the trunk. So not unlike measles where it starts kind of like cephalocaudally or from the head down. But then, over the next day or two, those macules start to evolve into a vesicle. And that's where you get that really classic description where you have a vesicle full of clear fluid on an irregular border. And so the PEDS boards want you to know that is a dewdrop on a rose petal, which is a very, poetic description of a kind of nasty virus. But here we are. After that point, the vesicle starts to become cloudy in terms of the fluid that kind of fills it, and then slowly it becomes umbilicated, and then it becomes crusty. And usually by the time the first crop of lesions start to crust over, you start getting development of new lesions. And so typically children will keep developing new lesions for up to 7 days, following the first onset of rash. But you'll see these lesions in different phases of crusting. This is in contrast to smallpox that have lesions that are all kind of in the same phase of being a vesicle and then crusting over. And in fact, varicella used to be thought to be just a weaker related cousin of smallpox, but obviously it's a different virus.
But that one's not coming back. We all agree on smallpox is not coming back.
Yeah, we're all happy about it too. Yeah, we don't want that one to come back.
Okay. So there are other, ways in which varicella can manifest. And if this is an okay time to kind of segue into it, among immunocompetent children, you can see pneumonia associated with varicella. And this typically happens about 1 to 6 days after the onset of rash, and so they're pretty closely approximated. This is just something that I always give anticipatory guidance to for families. Is that shortly after the rash starts or within about a week, you can start seeing respiratory symptoms. And it's often kind of the same kind of chronic, stubborn cough. But what distinguishes varicella pneumonia is that children can have pleuritic chest pain, and then hemoptysis is also an uncommon complication of varicella. Pneumonia as well. For the vast majority of children, this is a self-limited process. At about 72 hours, it goes away on its own. But some children rarely can develop respiratory failure and even ARDS and require ICU support for their pneumonia. And then just one other, I think, important kind of initial presentation of varicella that is less obvious are kind of the neurologic complications of varicella infection. So most commonly it causes meningitis. It can also cause encephalitis. There's an old review out of Germany in the 70s that 13% of their encephalitis cases were varicella, which is actually quite a lot because, as you may know, about 50% of our encephalitis cases have no diagnosis. So for 13% of that, of the diagnosed pie slice to be varicella, it can be decently neurotropic, particularly high enough case numbers, in the US having 4 million cases a year before vaccination. You can also get other neurologic manifestations. So cerebellar ataxia is kind of the classic one, attacking the cerebellum with VZV. You can also see transverse myelitis, and rarely children can even experience strokes if they have severe enough varicella encephalitis. And I think just the important thing to know about kind of these neurologic manifestations of varicella is that, in contrast to pneumonia, they don't coincide with that vesicular rash. And so they may just have the neurologic features in the absence of, the classic kind of chickenpox skin findings.
Oh, wow. So no skin findings, and then you have neurologic issues.
Yeah.
So then you have to have a high. Can you culture that in the CSF?
You can get a PCR off the CSF and find the DNA that way.
Okay.
And so we have decent methods of detecting it now, but you have to have that index of suspicion. Yeah, but I think it is increasingly become incorporated into our workup of diagnosis for encephalitis.
Sure. That's something to know in case there's ever an outbreak in the community and you start seeing encephalitis. You have to actually test for that. I don't think I knew that, especially without the vesicles. Okay.
Yeah.
So, and that kind of rolls into our next part, which was morbidity and mortality, even years later, sequelae. You talked a lot about meningitis, encephalitis, the pneumonia, potential for ARDS. Anything else you wanted to mention there, John?
Yeah. So, in terms of complications of varicella, the most common complications that we see are actually bacterial superinfections. So, the varicella virus itself, again, the vast majority of children do perfectly fine with the rash. But these develop a really easy portal for bacteria to come in and cause infections. And so children get cellulitis, lymphadenitis, abscesses, but really what matters most is necrotizing fasciitis. And so this was kind of a leading cause of mortality of varicella infections. And that's kind of back in the bad old days when neck fash was kind of monomicrobial and all group A strep related. And about 80% of group A streptococcal necrotizing fasciitis cases were associated with varicella. So the vast majority of those cases were, group A strep. And as you may know, necrotizing fasciitis is a surgical disease. You need to debride the affected tissue. Children and adolescents and adults can suffer amputations and have long-term disability as a result of these infections. And I think that's just a really important one to know because, again, necrotizing fasciitis is one of those conditions where you have to have a really high index of suspicion, in order to diagnose it. And just knowing that association that children with chickenpox are at high risk of neck fash, it's important to know. And I think it's one of the great benefits that we've seen of vaccination against varicella.
That's really good to review because we have a lot of community hospitals where they may have one surgeon or so, or hospitals without a pediatric floor. And if a kid comes into the ED with concern of varicella, to keep an eye out for necrotizing fasciitis, because to transfer to one of our tertiary care, quaternary care centers like ours may take a while, and it's an emergency. That's really good. Now here's where we normally talk about the data before and after the vaccination, which we've kind of discussed. Is there anything else you wanted to talk about?
No, I mean, I think it's hard to get really granular numbers in terms of our incidence of varicella, particularly because only 39 states are actually required to report their varicella cases. And a lot of what we have is dependent on passive surveillance. And so I think, staying alert to Department of Health alerts about varicella, staying keen to cases, because we may not have the same ready news about surge of cases in the same way that we do like measles.
Now, just recorded an earlier episode where it was 3 viruses, and when we got to treatment for patients who don't have the vaccine, the answer was supportive care because they're viruses. Is that the same answer for varicella?
For immunocompetent children who are doing well with their chickenpox, they don't need antiviral therapy. But we do have antivirals for VZV in acyclovir, and that's, varicella is not known to have resistance against acyclovir. We tend to reserve that for, the more severe cases. So particularly anyone who has neurologic disease, say if a patient did have respiratory failure from their pneumonia, and then certainly immunocompromised patients, which is just another kind of slice of the mortality pie rather, that I could talk about as well if that's an okay segue.
Yeah, let's do it.
Yeah, so I think one of the other big benefits of the varicella vaccine rather is just the protection of our immunocompromised patients. So for cancer patients in particular, they tend to be at really high risk of having complications from varicella. So they also have really high rates of encephalitis. They also can develop severe pneumonia or pneumonitis. And then they also get hepatitis that can result in DIC. So, some of the risk factors we think about is being really lymphopenic, so an absolute lymphocyte count rather, below 500. Or because the incubation period is so long, between like 10 and 21 days, sometimes these children can get a round of chemotherapy while they're incubating their new VZV infection. And that obviously is a huge setup for severe disease. So, in terms of treatment, like these obviously are the patients who, need the treatment with IV acyclovir. But going back to, otherwise immunocompetent Johnny down the block, they don't necessarily need treatment. And it's largely supportive care and then just really good anticipatory guidance. Again, think about things like pneumonia and necrotizing fasciitis.
That's fantastic. So immunocompromised patients with severe disease or severe sequelae in the hospital.
Yeah,
Fantastic.
exactly.
So for if there's an outbreak and there's a mix of vaccinated and unvaccinated patients, how would the vaccinated patients present if they happen to contract it because there's an outbreak in their community?
That's a great question, and I was preparing for this, and I couldn't find a really great answer about it. I mean, the reality is that natural varicella infection and also varicella vaccination provide really good durable immunity. I did find some immunologic evidence that parents who had chickenpox as children, who share households with children who get varicella, there's some like evidence of reinfection that they have immunologic changes that maybe they are like somehow responding to this new virus, but it's extremely rare to have like proper varicella disease if you've been infected before and you're immunocompetent or if you've been vaccinated.
Go
Yeah,
ahead, Bob.
I'll add there. I mean, I agree with John. It's highly effective and pretty rare to have breakthrough. This is essentially what we refer to as breakthrough varicella, and so when it does present, it can be actually really quite subtle. I've seen a couple of cases, literally, I think maybe 2 cases in my in the last 15, 20 years, and it can be very subtle. So what you'll often see is a limited febrile illness in the rash. The vesicular, the sort of chickenpox rash will look like, a lesion will look like a varicella lesion, but it won't follow, as John sort of eloquently described, the like dewdrop in a rose petal and clusters upon clusters coming out. So the rash itself can look a little bit modified, and the natural history of the disease progression will look modified. So, even those who are vaccinated can get varicella in when they're exposed. Usually, it's in those who are years out from either their primary infection or vaccination. So it can be a little tricky.
So, and neither of you found cases where someone who had varicella, who had vaccination, who had a breakthrough, had a severe sequelae like encephalitis or the necrotizing neck fash or anything like that.
I haven't. I don't know if you.
No, I mean, that would be, no, I didn't. I've not seen that personally.
Okay.
I mean, I suppose it could happen, and more so, I'd be worried about folks who have, waning immunity from, as we know, either they're getting cancer chemotherapy or T cell immunomodulation or something like that. So that could happen, but the likelihood is very low. And your otherwise sort of healthy kid who got immunized 4 or 5 years ago, I think the risk would be pretty low, even if they had breakthrough disease.
Well, Brian, this is a great segue into rotavirus because now we've kind of finished up with varicella and we're going to dive right into rotavirus. So take us back, microbiology 101, first year of med school. Tell us what we should know about it. And remember, we had Paul Offit on in the first episode, who's one of the founders of the rotavirus vaccine.
Well, right. One of the yes, I'm well aware. I've heard. I know Paul, though not well, and I've heard many of his talks about the rotavirus. Rotavirus biology, rotavirus vaccine efficacy, rotavirus. Because I agree. I don't know. I'll have to flip and just ask a quick question, Tony. I know the answer to John, which is you trained after the rotavirus vaccine was routinely recommended in the United States. I completed medical school in 2006, which was the year that the second generation, if you will, rotavirus vaccines were approved. So I was around and actually in residency when there was still a high burden of rotavirus disease. I don't know, Tony, I'm not trying to date you, but were
That's
you in
okay.
training then?
That's when I was in training. So I finished med school in 2007, and they had just taken rotavirus like kind of off the market because of the interception issues. So I was in residency, and we had a lot of rotavirus. And then I think somewhere through residency, the second vaccine came out, and I saw everything kind of drop, or towards the
Yeah.
end of residency. Yeah.
Yeah. So, all right. So then you've lived the experience.
Yeah.
Because I'm admittedly, I've seen varicella, but I talked to some of my, I have many gray hairs, but I have some colleagues with a lot more gray hairs who talk about the Hib days or the pneumococcal,
Sure.
before those vaccines. So anyways, I was just trying to get some context there. But so what do we know about rotavirus? I'll give you the 101. So rotavirus is also, as is the name, it's a virus. It's a double-stranded RNA virus, and as such, I'm not a virologist by any means or training, but I'm familiar with how this works. It's one of the reoviruses, and so there really aren't many. There's reovirus, which infects lots of kids and causes minimal disease. Rotavirus has been around, first described in the 70s, and it gets its name from its appearance under electron microscopy. It has a sort of wheel-like structure, which wheel in Latin is rota. And so the first scientist who identified this diarrheal etiology named it the rotavirus. And so from that time, when it was first described, obviously it was known to be around in hindsight since well before 1973. But in through the 90s, it was estimated that, and I'm going to have to sort of try to break this down, so bear with me, but in the United States, there were somewhere like 2 million cases per year. And well, that's a little bit vague, but upwards of 55 to 70,000 hospitalizations in the United States. So about 1 in every 72 hospitalizations for kids under 5 was due to rotavirus. So a substantial burden on pediatric healthcare infrastructure. And in the United States, the mortality was actually relatively low. We were talking less than 100, somewhere in the ballpark of 20 to 60. And that's wonderful. But this is an organism that was infectious. It's nearly ubiquitous in children under the age of 5. Frankly, upwards of 80% of kids under the age of 2 will get an infection with rotavirus. So suffice it to say, every kid gets rotavirus in the pre-vaccine era. And that data in the United States is very similar, depending on which study you look at, from European centers. And a lot of the studies were done in Belgium, Finland, and elsewhere. But those sort of burdens of disease are about the same. The mortality is relatively low. This contrasts with if you flip to the non, if you will, quote unquote, developed countries in the pre-vaccine era. The global burden of rotavirus was upwards of 20 million cases per year, more than 2 million hospitalizations worldwide, and somewhere between 500 and 600,000 deaths in children under the age of 5. So, this is in stark contrast to the less than 100 cases of pediatric deaths in the United States, and similarly in Europe. This is a massive burden on the healthcare infrastructure in the United States and in Europe, but it's a massive burden on childhood mortality worldwide. So that's where the impetus for developing better preventative measures and treatments sort of came from. In the post-vaccine era, depending on the study and the sort of epoch, if you will, the era at which people are looking, somewhere between 75% vaccine reduction or a vaccine-associated reduction in the burden of disease and sort of real-world practice. In the studies, the two key sort of landmark studies for the vaccines that we'll get into in a little bit were published in 2006, and they showed somewhere between 85 and 95% efficacy, meaning reduction in hospitalization or severe, medically attended gastroenteritis from rotavirus. Interestingly, the reduction post-vaccine in the underdeveloped or undeveloped countries was less so. And initially, it was not well appreciated as to why that was the case. And in the decades of research since then, I think folks have learned a lot about natural boosting that happens in underdeveloped settings, as well as malnutrition and other chronic and recurrent intestinal infections. So the microbiome and the immunology of the intestine actually have a lot to do with the susceptibility to infection. Does that answer your question about the 101 of the virus and the epidemiology?
85-95% reduction is fantastic.
Yeah.
So now, take us back, Brian. So if we did not have the vaccine, which a lot of people, we took care of patients that didn't, and we got the infection, what would we look like?
Yeah. So this was like many, so what people will probably think of now or think more like norovirus, but the symptoms were, so the typical course for a kid with rotavirus is you're infected, daycare or preschool or wherever, maybe from your older sibling. You have no symptoms actually for the first day or two when you're in fact infectious. So you can shed virus prior to developing the onset of clinical symptoms, which when they develop usually in the 24 to 72 hour post-infection mark are going to manifest as vomiting, typically preceding fever, which is pretty common, but not ubiquitous, and then diarrhea. So it was vomiting, then fever, and then diarrhea. And when I mean diarrhea, I mean lots of diarrhea. Parents would typically you'd ask them like, how much, what are we talking about diarrhea? And they're like, well, I change his diaper every 15 minutes over the course of the day, which is why, as you'll recall, we'd see these kids in the emergency room regularly and often admitted to the hospital with dehydration. What would get these kids in trouble is, you have a 3-month-old who's putting out 20, true diarrheal stools a day, and they get massively dehydrated. So that was really the issue. And associated with that, there'd rarely be, liver function dysfunction, or liver dysfunction, I should say, and electrolyte disturbances. But really, it was all about the diarrhea. There's not much to speak of in terms of, like a viremia, though it is detectable typically when people looked at the studies, are able to identify the virus in the blood, and occasionally get it out of other tissues if they look hard enough. But this is mostly a mucosal and intestinal infection.
So now you've talked about the mortality rate, both worldwide and in the U.S. I don't remember any sequelae for rota, but am I right about that?
Yeah, I interestingly, no, it wasn't well understood that there were sort of long-term ramifications of having had rotavirus. It was burdensome. Interestingly, since the vaccine, there has been an observation, like epidemiologically, there's a reduction in the rate of seizures in vaccinated individuals. There's a study that came out of Spain, and also a reduced risk of celiac disease. And so there may be sort of unrecognized benefits of the vaccine, which would suggest that perhaps some pediatric seizures or febrile seizures were in fact sequelae of rotavirus infection. So yeah, it's sort of fascinating what you find if you just sort of sit back and observe.
Yeah. Yeah, it shows you there's more we have to learn. That's fantastic.
Yep.
We've talked a lot about, you already told us about before and after vaccines were passed, and you've talked about patients being admitted and supportive care of IV fluids, et cetera. Is there any other treatment we have for this if someone doesn't have the vaccine and get rotavirus, or is it just fluids and hydration?
Yeah, for the most part, it's fluids and hydration. There were a couple of studies, and it's not trivial. I mean, the oral rehydration therapy is key. And obviously, in resource-limited settings, it is the life-saving intervention. I mean, but as far as medications, mostly things like probiotics have been shown to shorten the duration of illness, not prevent it or do anything like that. And then treatment with antiemetics like ondansetron, things that act on the sort of neuroenteric portion of the nervous system, are really key to slowing down the profuse vomiting that can come with it. But for the most part, it's oral rehydration therapy. Actually, breastfeeding, I want to be clear that breastfeeding should continue. For those infants who are breastfed, there was often some question about should you keep breastfeeding? Should you not breastfeed? You absolutely want to keep breastfeeding. There's, in addition to rehydration and the benefits of breastfeeding writ large, there's thought to be some antibody and immune value, if you will, immune-mediated value in breastfeeding in the context of rotavirus.
So now, if we are in a community that the vaccination rates go down, but we're vaccinated, and there's an outbreak of rotavirus and we get it, does the vaccine protect us against severe disease? Will we get a little bit of nausea, vomiting, diarrhea, but not as much?
Yeah, the short answer is your vaccination does not provide protection, even as they're designed, these vaccines, when folks study them, they don't prevent infection. What they do is typically reduce disease in a population and reduce disease severity in a population. Interestingly, it also has had impact on the epidemiology, in such that, this vaccine is recommended in the first 6 months of life or in the first year, right? And what was observed after the sort of more widespread rollout of the vaccine is that rotavirus didn't disappear, obviously, but that the burden of disease shifted to older kids. So while it used to be ubiquitous under the age of 5 and more prevalent under the age of 2, the burden of rotavirus disease shifted such that now children, 5 to 15 were actually seeking medical attention due to rotavirus, probably because they were protected when they were younger and then their immunity waned, is essentially the key reason for that change in epidemiology.
This is a fascinating one because I remember residencies taking care of a lot of kids with rotavirus, and then I remember it going away. And now this year and last year especially, it almost seems like that time period again because norovirus has really taken hold and made landfall from cruise ships and kind of stayed here. And so we're seeing a lot. So it reminds me of that time very strongly.
Yeah. I mean, the two main players in viral gastroenteritis for a long time were rotavirus and norovirus. And the burden of rotavirus, when you look at the sort of year over year, epidemiology, was this would come on in the winter, depending on where you lived in the United States, at least early winter in the South, late winter further in the East and North. And then it would sort of, in the post-vaccine era, there was really no seasonal trend. There was a little rise and then a dip, but it's all been sort of overwhelmed now with norovirus.
Yeah. Well, this was everything we wanted to cover, and I always give our guests an opportunity to bring up anything that we did not talk about that you wanted to talk about. John, we'll start with you and kick it right back out to Brian. Anything that we did not discuss with varicella that you wanted us to make sure we knew, or with rotavirus?
Yeah. If you're counseling families about vaccine hesitance for varicella and none of the other stuff I mentioned compels them, the last thing is just the prevention of having shingles or herpes zoster, that reactivation. The vaccine strain of the virus is way, way, way less likely to cause shingles. And so that's a huge benefit to vaccination that'll benefit the child even later down the line, even if they're not scared of chickenpox as like just an infection in childhood.
That's fantastic. If you can avoid shingles, that's always a good idea. Brian, what about you?
Yeah, I agree. I appreciate learning everything from John, even though I think a lot about varicella disease. It's always good to hear from the astute Dr. Albert. When it comes to the rotavirus, a couple things, Tony, you touched on that I want to be very clear on. So there are three, the history of the rotavirus vaccine, let me back up. So RotaShield was the first rotavirus vaccine that went on the market in 98. It came off the market in 99 because there was, after they did the clinical trials that showed the efficacy, which was proven, they noted that there was a rate of about 1 in 10,000 in their study population that developed intussusception, which was not something that they were specifically looking for at the outset. but they noted, and it was high enough, and I won't get into the sort of like policy/legal aspect of that, but Wyeth, who was the company that helped develop that vaccine, pulled it off the market in 99. When they went back and looked, probably the rate wasn't as high as 1 in 10,000, maybe higher, like 1 in 30,000. Although you could ask Paul next time you have him on, he'll give you all the details because he was intimately involved in the basic biology and the conduct of those studies. But because of that, after it was off the market, these two other vaccines, Rotatech, which is the 3-dose vaccine that's approved worldwide and and FDA approved and given in the United States, and Rotavirus, which is the 2-dose vaccine, which is also FDA approved and approved worldwide. When they were rolling out those studies, they were, in addition to looking at like vaccine efficacy and antibody studies and everything, they were laser focused on the risk of intussusception. And so they powered these studies up, not just to see if they could prevent rotavirus infection and disease, but to see if this rare adverse event of intussusception and all the other adverse events that one might look for in any sort of clinical trial were there. And they did not find it. The rates of intussusception, they occurred within the first month post-vaccine, but they occurred at the same rate in the placebo group as they did in the vaccine group. And I just want to be clear about that because intussusception, we're all pediatricians. We don't like to see bad things happen to kids. And so when this was a known thing, everyone wanted to make sure, first do no harm, that doing this was not going to cause harm. And so they looked, but in both of these studies, but the one by Ruiz Palacios it was published in New England Journal. That was the study, the Rotavirus. They saw no increased risk of intussusception. And then the other study of the Rotatech, which was by Vesicari, they also saw no greater risk of intussusception than the placebo group. And that's critically important. I think that's why I think we can confidently say that these vaccines do their job in preventing rotavirus disease, but they don't do more harm than not. They don't cause a greater risk of intussusception.
Ryan, do you have the years the Rotavirus and the Rotatech came out?
2000. I'm pretty sure 2006. Both of them were approved.
Okay.
Yeah.
So that would make sense why in med school I was seeing more, and then midway through residency it kind of caught on, and I started seeing less. It's right around that time period.
Yeah. Exactly. And it wasn't. The ACIP did recommend both, I think, later in 2006 or shortly after these studies came out. But sort of widespread clinical adoption, takes a little bit of lag time. So it wasn't really until 3 or 4 years later that we saw high levels of uptake from a population standpoint, and the sort of change in the epidemiology in the United States.
Oh man, that's fantastic. Well, Brian, John, thank you both so much for being on the show. I learned a ton. This was a great review. I really appreciate your time and expertise.
Thanks for having us. It's been a huge honor to be on the show.
Yeah, it's great. I appreciate it. Thanks, Tony. It only took 10 years. Maybe in 10 more, I'll do another one.
We'll get you back on for certain. Thank you both.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.